Are you a healthcare professional looking for a trusted concussion resource? Then you've come to the right place. From her New York City studios, welcome to Concussion Corner with your host, Dr. Jessica Schwartz.
And now, a word from our sponsor. Did you know that sport helmets are rated on a 5-star system similar to cars? And the safest helmets have nothing to do with price, brand, or availability? Since 2011, Virginia Tech researchers have been providing unbiased helmet ratings that allow consumers to make informed decisions when purchasing helmets. The helmet ratings are the culmination of over a decade of research identifying which helmets best reduce concussion risk. This work is done as part of Virginia Tech's service mission and is 100% independent of any funding or influence from helmet manufacturers. Our mission at Concussion Corner is to expose you, the listener, to trusted spaces in the concussion arena that translate to clinic next day. Please visit the Virginia Tech Helmet Lab website in our show notes or at bit.ly/Virginia Tech Helmets and spread the word to aid in lowering concussion risk in your community. Thank you for tuning in, and let's begin the show. Welcome to Season 4 of Concussion Corner. My name is Dr. Jessica Schwartz, and I'm thrilled to have Dr. John Heick on with us today. Dr. Heick is an associate professor at Northern Arizona University in Flagstaff, Arizona. He is triple board certified as a physical therapist in orthopedics, neurology, and sport, and received his PhD in 2015 from Rocky Mountain University of Health Professions in orthopedic and sports science with his dissertation on concussion assessment. John, welcome to the Concussion Corner podcast.
Thank you, Jess. Happy to be here.
I'm happy to have you as well. And, we're New York to Arizona and, just entering into spring. So I know you guys have ideal temperature in the weather. How's your biking and your weather been this winter?
It's been kind of weird, kind of off and on with a few snowstorms. We did have 37 inches in the January timeframe, which is quite a bit of snow. Definitely not biking during that time period, but yeah, now it's been kind of nice, so you can take advantage of the weather for sure.
Awesome. Yeah, I actually never asked you, what kind of bike do you ride?
I have I went from a Trek to now a Mossy, and so I don't know, and maybe you're familiar with that because I think they're actually built in somewhere in the Northeast, north of you. But yeah.
Oh, very cool. Yeah, I'm a Trek and a Specialized gal. We have a little bike garage, 4 bikes between 2 of us, and 3 of them are mine. But so I appreciate anyone who cycles.
Yeah, well, I had a Trek and a Specialized as well, and unfortunately left the garage door open one day, and
oh no.
Yep. Walked away.
My heart hurts. For
I know. It's terrible.
I got my bike stolen early in college, and I've never been the same. So I think I have, as a true New York City person, I think I have close to $500 in locks. Wow. Yeah, I don't play around with them, but most of them live inside 99% of the time. So
right next to the bed or the safe and everything else,
much,
right?
The ceiling, the wall, they're everywhere. Yeah, I'll send you a picture after we.
That's great.
That's great. Yeah. So I'm so pumped to have you on the podcast. I just tweeted at you the other day, and I'm excited that you're a newer person in my purview, and I'm so glad that we can have you on so quickly to talk about this new article that you just published. And essentially how the podcast usually works is, anytime there's somebody new on the podcast, I just love for the listeners to get to know you. We're in, close to 50 countries right now, with coming up on 50,000 downloads probably in the next month or so. So, we just like to let the listeners kind of key into, this is a podcast for healthcare professionals. And so I'd love to kind of hear how you entreed into your vestibular and concussion work, and storytell that so we can kind of get to know you.
Absolutely. Yeah, it's actually started when I was a young child. I guess I was somewhere around 10 years of age, and riding a bike, back to the bike idea, and riding bike with my mom and my sister. We're riding along in our neighborhood, and we wound up going down this very incline, this very large hill, And next thing you know, my mom kind of lost control of the bike and went down, of course, face planted, and got off the bike, ran over to her, lifted her head up, and saw this terrible scene of, my mom was knocked out and blood pouring out of her forehead. And I thought at that point, she's gone. She's dead. And it was a terrible experience. And at that age, the feeling of hopelessness and not knowing what to do, what could I do? And of course, as boys being different from girls, I sat on the curb. And my sister,
head between the knees,
and my younger sister kind of started screaming for help and everything else right off the bat, and went to, up towards the neighbors, one of the neighbors' houses, and of course a neighbor came out and helped out. But long story short, Mom was fine. She had a concussion, so we spent the night over in the hospital. Had a couple of sutures to fix her head up, in terms of the bleeding and everything. And that sparked actually my medical career. So I went in the Air Force, became a medic in the Air Force, did 12 years total, and wound up looking specifically at being able to do a job that, instead of a treat 'em and street 'em type of approach, got me more involved with the patient. And of course, that led me to physical therapy.
Awesome. Very cool. And thank you for your service as well.
Appreciate it.
And I think just for the listener listening to that story, and I think that story, listening to it, is just as dramatic as it was for you really living through it. I mean, it's a very hardy story. There was a big mechanism of injury. There was, something that happened to your mom that was memorable, and there was blood involved and a loss of consciousness. And just for our listeners to kind of key into that, that's kind of the range of what concussions can look like. They can be something that we weren't aware of until maybe a few days later, like you fell off of a bar stool, because we know that you don't need to hit your head to have a concussion. It can be a blow or jolt to the head or body to have a concussion. And then less than 10% of them actually have loss of consciousness, like your mom. And most of them don't have these other hardy injuries unless it's a trauma, if other concomitant things going on, like with blood and things like that. And what's good to know is that a lot of folks here, John, and for our listeners to tie into, is that, at the end of the day, you don't have to lose consciousness. You don't have to have a major trauma with blood and other things going on. But it's good to know that if you are seeing these folks in the clinic, that were they screened for concussion? That's it. Because of someone like your mom, I'm sure did she have stitches?
She did, yeah. She, in terms of, checking her out, I think at that time, I remember there being obviously radiographs being done, but I also think she went for an MRI. Of course, that was negative for any significant damage. And like you brought up in terms of the concussion, we know that even with imaging, that's not necessarily going to show that someone's had a concussion, right? So like you alluded to, that loss of consciousness is not going to predict the severity or the recovery aspect as well.
Indeed. And that's so important to hear. And I've actually read a few papers, and I'm sure you have as well. And I'd love to hear your thoughts here. But we actually, and even clinically and anecdotally from my N of 1 of treating patients myself, I even find that oftentimes with a loss of consciousness, I actually find that there is some kind of protective mechanism there where I actually don't see very severe, like persistent post-concussive patients that have had loss of consciousness. Like you see these hardy rollovers with other concomitant things going on, whiplash disorders and things like that. And then in terms of persistent symptom concussion wise, I tend to find them to be somewhat protective. And so that's what some of the literature has said as well.
Absolutely. Yeah, absolutely. I see the same sort of pattern in my clinical practice. I know I primarily teach, but I also work in a pro bono clinic here in Flagstaff, as well as continue in the clinic, of course, to, like I said, for the certifications to maintain my hours. So absolutely see the same pattern.
Yeah, I hear you. And we've had folks from the CARE Consortium in, which is the Department of Defense and NCAA joint venture in concussion research. And they're looking at everything from blood work to imaging and things like that. And I think it's so important that we have you on because you're really expert in the vestibular area, really looking at, ocular motor function and vestibular function. And those things aren't picked up on imaging, right? So it's so lovely to have a conversation with a clinician right now. And we're actually going to break down some of the things that we can do, somatically on a point of examination to look at kind of, deeper in, what's being missed on, plain radiographs and MRIs and CT scans and things like that. Again, those catch the big nasties, but in terms of the pathways and the demyelination issues that we see later on in life, and folks that are having more, either cognitive issues and things like that, it's so wonderful to see folks like yourself really trying to standardize, examination tools and principles that we need to have in our toolbox. So I'm pumped to talk to you about your new research paper.
Yeah, I'm very happy to be here and chat about that. And I think that you're right on in terms of looking at standardization across concussion, across all these different healthcare professionals that are looking at individuals, whether that's in care home, because this, of course, a concussion can happen in a geriatric population, pediatric population, sports, all of these different areas. And potentially then, whether you're an athletic trainer or a physical therapist or a concerned mom or dad, and have your kid go down with a concussion in either sports or playing on playground equipment, for example, that definitely can, you will see this, right, in our everyday living.
Indeed. And, in terms of myself is I tend to have folks reach out to me. And I think folks like yourself in the vestibular world and neuro PT world tend to see this as well. They're not the first line of defense usually with concussion evaluation. Usually it's either athletic trainer or a primary care physician or maybe a direct access orthopedic or sports or generalist PT before they get to the vestibular specialized physio. So I would love to hear, let's just let the audience know. So this article that John published with his colleague Kurt Bay here was published in the International Journal of Sports Physical Therapy. And I believe it's free open access if I...
It is, yes.
Yes. So we really support the FOAMED movement here on Concussion Corner. FOAMED is hashtag formed by the emergency medicine physicians, and it's called Free Open Access Medical Education. So we fully support that, and I'm so glad that folks that are not involved in institutions can have access to this paper as well. So we'll put that in the show notes, the link of this paper. The paper is entitled "Determining Near Point of Convergence: Exploring a Component of the Vestibular Ocular Motor Screen, Comparing Varied Target Sizes." Now, I'm fascinated and just curious, and this is the nerd in me. How did you even come into this? Come into the idea of let's do this paper. I'm nodding my head in excitement, like a happy Labrador over here. But for folks that don't, aren't in our space, how did you even come to this idea of doing this research?
Yeah, I think that, we have all seen this happening on television, especially if you're, watch sports, in terms of the individual that, gets his bell rung, winds up male, female, and winds up having a concussion and is being evaluated on the sideline by, a physician, we assume, maybe an athletic trainer. I'm not sure who. We don't really sometimes know if that person's, the sports announcer will announce who it is. And they sort of go through this kind of quick kind of pattern of using their finger. They'll move their fingers side to side and very quickly. And it kind of has, we don't really have any standardization, or at least didn't. And so I was seeing this happening in just watching sports and athletics and things. But then also when you start to dive into that, in terms of doing vestibular rehabilitation and through the training, we use different objects to, whether it's smooth pursuit, and have the individual that we're testing track that finger or track that target. And so the thought arose kind of from just watching this happening. And then, of course, this is in clinical practice before the VOMS, the vestibular-ocular motor screen, came out. I was seeing this in clinical practice in terms of looking at these different components in patients with vestibular problems that I was treating for vestibular rehabilitation. And if you went to, one continuing education course versus another, you would hear these different approaches and, oh, well, this is how I do it, or this is how I do it. And how, these clinicians would, create a different object that they would use to have the individual track that target. There's no standardization. And then lo and behold, and Muka comes out with the VOMS paper that I just love, because in terms of using the zero, the scale in terms of the dizziness, in terms of the headache, when that came out, it was just, and to me, I don't know about you, Jess, but sort of life-changing. And it validated the idea of looking at these very specific things and doing it a standardized way. Mm-hmm. So that, from that emerged this idea for this paper of looking at one part of the VOMS. The VOMS is an excellent tool, right? The vestibular-ocular motor screen is an excellent tool. But
yeah, and I hope that we see the VOMS. Oh, I'm sorry to interrupt, John, but I really hope that we actually see the VOMS in our future international consensus statement for this year that will come up in the fall. It was pushed due to COVID, but I really hope that we see the VOMS at least mentioned for consideration to incorporate that into the consensus statement for future. So I'm looking forward to kind of seeing where that comes, and I'm actually hoping that we'll use this paper for those talking points.
Other evidence like the concussion clinical practice guideline that was published as well, it specifically points out the VOMS. And so I think there's, evidence building that not only should the VOMS be done, but it should, now there's papers that are coming out that saying the VOMS should be done as a baseline measure. Mm-hmm. Now, in terms of efficiency, and when we think, to the clinician, athletic trainer, the physical therapist that's evaluating 110 athletes, for example, the time issue becomes a concern, right?
Right. Yeah, and we've seen that even with John Letty, who's been a friend of the podcast on a few times already. Even his concussion toolbox, he's even I don't want to say dumbed down, but he shortened it from like a 30 to 45 minute exam to a 7 to 10 minute or shorter exam once you become a proficient at it with his, I think it's the Buffalo Concussion Physical Exam that he's published on, adapted. I think that was 2018 or 2019 he published that. And that was amended from his 2015 or 16, I think it was 16 in the sports journal, his concussion toolbox. So with, I think, Matuzak et al. So I totally respect that in terms of time and how do we, I think that's a conversation for folks that aren't well versed in the field is, hey, we have screenings for sideline and those can be a few minutes because really it's a go, no go, right? At the end of the day, I mean, if we take any clinical doctorate title out of it or athletic training title out of it, yes. It's when in doubt, sit them out. That's Jimmy's right. Jimmy's running in the opposite direction on the soccer field after having a collision mechanism of injury. Jimmy needs to get taken out. Jimmy does not need a 37-minute neurological evaluation, hands-on. Jimmy is out of the game for that moment.
Right.
And then it becomes a generalist screen and then a more specific screen. So I think these are great conversations to have so people know like, hey, this doesn't need to be a 4-hour physical exam.
Exactly. Yeah. And so any way that we can, make it more efficient but also make it as precise as possible, not accurate, but precise as possible. So that's kind of what this paper was about then, was sort of looking at one part of the VOMS, vestibular-ocular motor screen, and specifically convergence. And when we look at the different types of things within the VOMS, of looking at the different systems, like the smooth pursuit system, like the vestibular-ocular reflex system, if you will, that we know the least about convergence. And so when we look at the different disciplines that have done research on convergence, there's not a full consensus in that. In the discussion, I described some of the aspects of looking at one discipline versus another discipline, of how they would look at this, and it's done differently. And so in looking at the research, of course, looking at the different sized targets, that has sort of brought up a number of questions that I discussed within the discussion about how one discipline does near-port convergence versus another discipline.
And yeah, I'd actually love to hear about that if you'd be open to sharing, optometry versus neuro-PT versus, OTs and others.
Yeah, absolutely. And so when we look at the different disciplines, I think one of the biggest things is we have to have some kind of agreement between the disciplines of how we're going to do this. Again, vestibulo-oculomotor screening specifically says we're going to move this target towards the patient, and it doesn't give an idea of how fast we would move that target. One paper you mentioned, for example, the ophthalmologist Adler et al. Specifically looked at moving at a specific speed. And I think the speed was, let me make sure I have that right, was 1 to 1.2 centimeters per second. So if you will, they were moving at a specific speed towards the patient, towards the bridge of the nose. So when we look at the convergence, we will normally see both eyes, pupils, 80 duct towards the target. And as they're doing that, you're asking the patient about when they start to see double. So it'll be normal to have some blurred vision before it actually doubles. So in our language to capture convergence, when we test that on an athlete or test that on an individual, we should be saying the same thing throughout, and we should be doing that at a certain speed. If we move too fast, like you see, or in my reference back to the physician or the athletic trainer that's quickly moving his finger back and forth, then we're actually using a different system than looking at convergence. And it might be too fast for that individual to pick up that difference between blurring and double vision. Does that make sense?
100%. And,
Okay.
Just from the saccadic aspect of these are quick, rapid eye movements, we want to make sure when we're looking at smooth pursuit, we're not tapping into the saccadic system. And when we're, looking at this convergence that you're talking about, we're also not tapping into saccadic eye movements, because those really light up the brain in so many different ways, as opposed to smooth pursuits and so on and so forth. So, no difference than the way in which we dose exercise. We're looking at frequency, intensity, duration, and so on. We need to think of this with eyes and with eye teaming and accommodative and, unilateral eye use. It's so important for folks to think of it, as physios, as athletic trainers, occupational therapists, whomever. We think of things very gross motor, gross anatomy. So we think of the bicep, and or the glute. We can tell you that it extends, it abducts, and it externally rotates the hip, for example. But we have to remember that the eyes are no different, in that, once you start to think of the eyes like a gross motor joint, like a shoulder or a hip or something like that, things start to really make sense. But you really have to get your neuroanatomy down. So again, John, Dr. Heick here is talking about, basically pacing and speed, and, for looking at eye movement is so very important to listen to, because it's the number one thing that I see, that when people aren't comfortable with the neuroanatomy, or with looking at anything ocular motor, again, we have to know what we're looking at, so we know what we're looking for. So just listening to him, speak about all these things are very, very important, if you're going to introduce this next day into your clinic. So, thank you for bringing up, some of these salient points.
Absolutely. And I think you're just to capitalize on that and add to that, these different systems then use different real estate or neuroanatomical space in the brain. And so when you move from convergence and move into more of smooth pursuit, then you're actually evaluating another part of the brain. And the oculomotor system as a whole, we know that about 60 to 85% of individuals with concussion wind up having some kind of ocular involvement. And so we think about that real estate, more than 50% of our brain is used just for vision. So like you said, we should use the eyes to help us identify that abnormality.
Indeed. And even from a sensory standpoint, we know that 70% of our sensory environment is also come through our vision, our ocular motor system. So again, you have the greater than 50. I know that about the 2/3 of the brain's pathways are devoted to vision. Again, huge chunks of real estate are devoted to vision at the end of the day, no matter what metric we're using or percentage. So the fact that if you can really hone in, and I really think, John, that this is the future, or it's either present day you're really excelling at concussion evaluation, treatment, and management, or future, you're building up your concussion Rolodex of knowledge. This is really the future. Looking into the eyes, they're literally the windows to the soul, and really to brain function. So if we can capitalize on doing really good, comprehensive, targeted physical examinations, including ocular motor functions and dysfunctions, I really think that's the future of concussion assessment.
I agree.
So, now, in terms of, you were looking at 9-point, 14-point, and 12-point fonts. Is that correct?
Yes, and so the 9-point font is actually on a small battery operated device. Looks kind of like a black box about the size of your hand. It's called the Bernal Virgil. I have no ownership or conflict of interest with this company.
Sure.
And the tip of a black pen, which is a common thing. The 12-point font or the 14-point font, both of those have been referenced in the literature for the VOMs. When Ann Muka originally did the VOMs as a study, used the 12 or the 14-point font. So yes, the 9-point font was on this little black box device, the tip of the pen, and then I looked at the standard. They use a X that's put on the end of a tongue depressor for 12-point font, and then also for 14-point font. And I marked those to make sure I knew the difference between, this one's a 12 and this is the 14-point, just to make sure I didn't mess that up in terms of testing. But yes, that's correct.
Okay, that's awesome. And you use black font throughout?
I did, yes.
Okay, yeah, and I know, at least I know in terms of folks like the KD with the King Divic, I know that they only use they went from using cards to the Apple iPad, and I did ask Steve Devick, hey, why aren't you using Android tablets? And he said it's actually standardization of color, so they know like the nits and the output that's coming for contrast, because that's very important to our ophthalmology and neurooptometry friends. In terms of testing, in terms of standardization. So that's good to know that we're using as high contrast as possible.
Yeah, right. Absolutely. Yeah, I do have a paper on the King Divic, and I make within the discussion, I make the point specifically. It's also an International Journal of Sports PT article that you could look up. I make the point that when King Divic converted over from the paper to the Apple-based product, that I understand why they did that, but in looking at that changeover, the two tests, we wind up seeing, if you look at the two, and that's what I did in the study, was looking at the computer-based version versus the paper-based version. They were actually a little bit different in terms of the time. So the key point I want to say about that is, if for some reason you have the paper version and you go to test them after they've had a concussion with the computer-based version, they don't equal each other. So if you test, whether it's preseason or after the concussion, you should use the same. You should use the computer. And I think the computer is only available now, correct?
That is correct.
The paper is no longer available.
Correct, yeah. So, and that's really good to know. And I guess it does make sense also from a within variability. So that's good to know.
Yes.
Okay, awesome. So in terms of, I know you had a 75N, you had 59 female and 16 male.
Yeah.
Was it 18 to 50, or I'm sorry, I didn't check.
Yes, yeah. So we wound up getting a mean age of 21-year-olds in terms of, and they didn't have to be an athlete. So again, just looking at the overall population, and we put this out. It wasn't just PT students. It was In fact, there were very few PT students. I work in a facility and teach physical therapy. We opened this up to all undergrads and all different individuals. And they what was nice is we tested a lot of individuals. So I think it was like 1,200 different near point convergence tests total.
Wow.
Yeah, that's a lot of people to test.
You were busy. Yeah.
Yes. Exactly. When we did that, what's pretty wild about that is for the VOMs is there's this cutoff of 5 centimeters. And so in the discussion, I talk about that. But again, we looked at, these are not individuals with concussion. And my point here is that 61% of the people that we tested didn't have a concussion. They actually were above that 5 centimeter cutoff. So if they were suddenly to have convergence tested on them, if we only use convergence, it would have been positive for a concussion, right? So that's somewhat of a problem in terms of this 5 centimeter cutoff that we use within the VOMs. I'm just identifying that within this paper that needs to be explored, and that also then supports the idea of looking at the VOMs as a baseline measure. Because if I come to the athletic season, let's say I'm in high school and I come to try out for track, for example, like my daughter is right now, then when they should administer the VOMs, but I might already identify that they have an 8 centimeter difference in terms of looking at convergence, right? So if that's the case, if my daughter were to have a concussion during the season, if they were to use that 5 centimeter cutoff, we would be saying that she had a concussion based off the convergence score, which is not the case because their normal convergence would be 8 centimeters. Does that make sense?
It absolutely does. It absolutely does. And even just in general, we preach as like folks that educate in concussion about, vision is just more than 20/20, vision is more than acuity. But this actually comes to the point of, well, actually, we should make sure that we understand what their vision is acuity wise, because if we're testing someone that can't see the stick at 14 font or 12 or 9, then that is a confounding variable for sure. So that's an excellent talking point, John.
Yeah, and what's wild about that is then when you look at the optometry literature, they actually suggest the normal NPC should be about 8 to 10 centimeters. So that's different from the 5 to 6 centimeters that we're using in a cutoff. And
correct.
If we don't
and that's what I've seen in terms of differentials and just having communication of just subjective conversations with folks. I've heard the 5 to 6 to 7 to 8 to 10. Yes.
Right. Yeah, that's potentially a problem, right? If that winds up being the case, especially if you were not doing a baseline measure, you would not know. For example, my daughter's example that I said, then if she had 8 centimeters and you didn't test her at baseline, you only tested her after a concussion, you would say, oh, she's got a concussion, but not the case.
Indeed.
Okay, so. Yeah, and looking at our population, normal people, again, as you pointed out, and in terms of numbers of looking at and doing measurements, we definitely tested all of them, and we went through and made sure that they didn't have any visual difficulty, oculomotor, any vestibular problems. They were excluded. But so when we look at these specific aspects in terms of convergence, we wanted to use different targets to sort of see if one was better or if there was a difference between one versus another. So, to cut it down to a small bite-size approach, size matters. Size matters.
Yeah, indeed. And actually, we're coming up towards the end of this podcast, and I actually kind of want to leave the listener a little bit on edge for our second podcast that we'll do, John. But I want to kind of lead them into, we're going to talk about near point of convergence, and also really how ophthalmologists and optometrists are experts in vision and brain, how they're also looking at near point of convergence as well. I think that's going to be, we'll kind of leave the listener a little bit on the edge of their seat, and then talk about your conclusions as well, as to why things should be standardized. And it will be helpful, I think, for like real world clinicians to potentially reevaluate themselves like same day in clinic and hopefully have some next day knowledge translation. So I'm excited to record up part 2 with you.
Sounds fantastic.
So, John, what's the best way for folks to reach out to you? Is on social media and things like that? If they want to reach out and say howdy.
Absolutely. I do Twitter. I don't do Facebook, but jheick1, my first initial, last name, and then a 1 for my Twitter account is definitely one way. You can find me through Northern Arizona University as well in terms of the faculty directory.
Awesome. And for those that are listening in, please, we just finished up Brain Injury Awareness Month in March. It would be lovely if you would consider telling one person about us. The motto of Brain Injury Awareness Month is more than my brain injury. And in the past, it's been not alone in brain injury. So by all means, folks are still learning out there. So if you can share this FOAMed piece of information with somebody would be fabulous. Every podcast takes 5 to 6 hours to produce and publish and all that jazz. So we appreciate you guys for tuning in. And John, I look forward to seeing you for part 2 of this podcast.
Me as well.
Thank you for listening to the Concussion Corner, hosted by Dr. Jessica Schwartz. The information in this podcast is for entertainment purposes only and not to be used as personal medical advice. Don't forget to follow us on social media on Facebook, Instagram, Twitter, and YouTube at Concussion Corner.